Hi, I'm Sean Fix with Emergency Medical Consultants. We're a national training center for a number of organizations providing continuing education for healthcare providers, fire, EMS, and industry. This video series that you're about to look at is designed to help you prepare for a certification course. Remember that it's not designed to make you leave your required manual or not do your required pre-course exams prior to entering the course. It's also a great review just for clinical practice and relevance. So in this section, we finalized putting it all together and overviewing the key points that you should be ready to test on, as well as the algorithms you should be ready to manage as a live case. So remember that you need to be able to interpret EKG rhythm strips when you get to your ACLS evaluation, whether we're talking about the written exam or whether we're talking about case management with a patient sitting in front of you. You need to be able to identify standard sinus rhythms or arrhythmias, atrial rhythms, junctional rhythms, ventricular rhythms, and there are a few heart blocks. So there's a review section that you should look at for EKGs if you haven't already done so, or if you're somebody who needs a little extra help with EKG rhythm strips. Things that we need to remember. During cardiac arrest, CPR is the most important part, and defibrillation every 2 minutes is the second most important part. And I don't know which order I would put those in, but what you need to remember is everything else is secondary, meaning that that doctor who says stop CPR because I have to intubate for greater than 10 seconds is making the patient worse. The nurse who says stop moving the patient around with all that CPR while I'm trying to start this IV so I can give meds is actually making the patient worse instead of better. So we need to keep that in mind. Remember that in ventricular fibrillation, which is the most common rhythm adults start off in cardiac arrest, every 2 minutes you should stop, reevaluate the rhythm, and be prepared to shock if need be. What that means is whoever's at the defibrillator should charge it up just before the 2-minute section if there's a chance it's ventricular fibrillation, so that we're ready to shock and decrease that compression fraction time. That is the time it takes to stop compressions, recognize VFib, shock the dysrhythmia, and then go back to compressions. Even though they give you 10 seconds to do it under most test questions, literature in the book, etc., truly what the science says is if you can do it in less, that gives us better chance of return of spontaneous circulation. The other thing you need to understand is the concept of 12-lead ECG and STEMI. Now, you're not going to be handed a 12-lead ECG and told to evaluate that and determine your treatment unless you happen to be a specialist who works with 12-lead ECG. So physicians, critical care nurses, advanced practice nurses, paramedics, they might give you some EKG, but there's not going to be a test that says determine this 12-lead. Remember what we said. If the patient has a STEMI, ST segment elevated myocardial infarction, he or she is a candidate for cardiac cath lab or PCI. And if you don't have the ability at your facility to get that done within 90 minutes or get them transferred somewhere they can get it done, then they may get a fibrinolytic like tenecteplase or Retivase for their STEMI and then sent to the cardiac cath lab. Remember that error reduction and team concept is important. The experienced person with medication should be the person pushing the medications. The experienced person with airway management, like the physician and respiratory therapist, should be doing the airway. And somebody should be documenting and charting and letting us know every 2 minutes. Remember that each member has to function within their scope of training, certification, and practice. That is, you don't intubate patients if that's not something that you're skilled at doing. Another team member would do that. If you're given a skill to do or asked to do something during the cardiac arrest that you don't do as part of your regular job practice and can't do, you should ask for another task. If somebody is making an error during the cardiac arrest, any type of error, somebody should mention that the error is wrong. Hey, shouldn't we push faster? Shouldn't we push deeper? Aren't we supposed to give 1 milligram of epinephrine not 100 milligrams of epinephrine. And our goal is do good BLS and occasionally add some of the ACLS medications to do that. So a couple of key points to remember. Oxygen is only given to patients who have a saturation below 94 if they're a stroke, or below 90 to 94 if they're an acute coronary syndrome, or if they complain of shortness of breath, or they have pulmonary congestion or crackles or rales with shortness of breath. Too much oxygen causes toxemia within this at the cellular level. Overventilation causes intrathoracic pressure, which decreases cardiac output. Hyperventilation causes cerebral constriction, which decreases blood flow to the brain. So when we're thinking about oxygen, give it judiciously and give it to the right patient. We have the ability to measure oxygen saturation with a pulse oximeter, which is a device we've been using for 40 years. Remember that waveform capnography, or CO2, really has only been used routinely probably since about 2015 or 16. So remember, in ACLS, we use it as the patient exhales. We measure his waveform and his numeric value, and we're looking for a patient who has his own pulse to have a CO2 of 35 to 45. A patient who has his pulse generated by CPR to have a rate greater than 10. And a patient who is intubated to have an exhaled CO2 reading with a waveform and a number. Those are the tools that we use. Waveform capnography, or end-tidal CO2, or PET CO2, all mean the same thing. Those are the devices that we use, or those are the things that we use that device for during ACLS. So even though the standard ACLS provider may not be using an automatic defibrillator as their main defibrillator during cardiac arrest, there are cases where that may be what you have. If you happen to be in a supervisor vehicle, a security car at a hospital, a building in a hospital that has an AED because there's not patients housed in that direct area, or anywhere else you may be, an airport, the supermarket, a mall. The thing that you need to remember about an AED is, as an ACLS provider, you sometimes try to get ahead of the AED. And what I'm saying is, you may turn it on and start putting the pads on and plugging things in before the machine is ready. So here's the simple version. Turn it on, stop, continue doing CPR, wait until the unit tells you what to do and do that next. Whether it says put the pads on, or push analyze, or stop moving the patient. Whatever it tells you to do that. Once we defibrillate the patient with the AED, or even a manual defibrillator, the default setting should always be start 2 minutes of compressions after you defibrillate every time. Don't delay to check a pulse, don't delay to check a rhythm. It should be the default setting, defibrillate, continue CPR for 2 minutes, and then reevaluate at the end of 2 minutes. Remember that either post-cardiac arrest with a patient who has respiratory arrest or agonal breathing, or pre-cardiac arrest with a patient who has that same condition, we would ventilate the patient at approximately 10 breaths a minute, or 1 breath every 5 to 6 seconds. Our goal is, if we've stopped doing CPR because there's a pulse, we then want to make sure that we're optimizing his oxygenation at 94 to 99% and optimizing his perfusion or ventilation at a CO2 of 35 to 45 millimeters of mercury. If we are ventilating a patient with a bag valve mask, we should probably put an oral pharyngeal airway into them. The oral pharyngeal airway just sits behind the tongue and keeps the tongue from falling back in the posterior pharynx. If we're able to use an oral pharyngeal airway just because we have one in our unit or our area, it's measured from the angle of the jaw to the corner of the mouth. So the proper oral pharyngeal airway, as you can see on the slide, bottom right, is measured at that length. One that is too small or too large will cause the patient to have an occluded airway potentially. Remember that if your problem is hypoxia, sometimes that can cause you to have tachycardias or bradycardias or ventricular ectopics, and fixing the hypoxia may solve your problem before you give medications. So as we reviewed in the initial section, peripheral IV sites are the preferred site of access if you're accessing them during cardiac arrest. Certainly, if the patient already has a central line in, utilizing the central line it may be appropriate as well. If for whatever reason you don't have vascular access and you can't start a peripheral line quickly or easily, intraosseous devices, whether it be in the humeral head, whether it be in the tibia, or whether it be in the manubrium, which is the top of the sternum, are the acceptable method as your next device. So let's talk about cardiac arrest management, and then we'll look individually at each algorithm for treatment. The general cardiac arrest management basically says this. CPR is the most important part. Defibrillation for ventricular fibrillation is the next most important part. All cardiac arrest will continue to get epinephrine throughout the code at 3 to 5 minute intervals, or what I say is every 4 minutes, because you're going to be stopping every 2 minutes to evaluate your patient. If the patient is in ventricular fibrillation in his cardiac arrest, along with epinephrine, after 2 minutes, he should get either amiodarone or lidocaine as an anti-dysrhythmic. Post-cardiac arrest, we said, optimizes oxygenation and ventilation, stabilizes heart rate, heart rhythm, and then blood pressure in that order. And then the last couple of things that should happen is we need to decide whether this patient is going to go to the intensive care unit or to the cardiac catheterization lab, PCI. And we do that by adding a 12-lead ECG. So when we add the 12-lead ECG, if the patient is showing STEMI, he or she should be taken to a cardiac PCI facility. I will tell you that there may be facilities who say if the patient has cardiac arrest, we are going to take him to the cardiac cath lab anyway. But as far as the ACLS standard goes, what they say is if it's STEMI, right to the cath lab. The last thing we evaluate is the neurological status, very simply. Does the patient respond appropriately to voice and or pain? If the answer is no, he may then be a candidate for induced hypothermia or target temperature management, where we drop his temperature to 32 to 36 degrees Celsius for up to 72 hours, or the general says 24 to 72 hours. So those are the things we need to remember. Let's talk about some of the specific algorithms now. So for ventricular fibrillation, which is going to be the same as pulseless ventricular tachycardia, the initial sequence is begin CPR. Begin CPR, as you can see, and then get a defibrillator in the room. As soon as available, defibrillate the patient at the appropriate energy for the device that you happen to be using. Do 2 more minutes of CPR, have the defibrillator charged at the end of that 2 minutes and ready, and determine if it's ventricular fibrillation again. If it is, then you should defibrillate the patient. At this point, you will start with epinephrine. So in ventricular fibrillation, we're going to do a defibrillation, 2 minutes of CPR, defibrillation again before we start with our epinephrine. After 2 minutes of CPR, reevaluate the patient again. If he's still in ventricular fibrillation, defibrillate. Hopefully your energy was already charged, and give him 300 milligrams of amiodarone that hopefully was already drawn up for you. So understanding the algorithm with the 2 minute sequences gives you plenty of time, even if you had to look some of this up on a reference card. In your next 2 minute cycle, the patient will get epinephrine and a defibrillation, provided he stays in ventricular fibrillation. And following that, the patient will get the second dose of amiodarone, which is 150 milligrams, and another defibrillation. From that point on, we look at the H's and T's, if we haven't already done so, to determine why this patient might stay in ventricular fibrillation. So at that point, the physician could order a drug to manage those other issues, potentially magnesium, sodium bicarbonate, along with epinephrine, based on the patient's history. So if we look at the asystole or the pulsus electrical activity algorithm, we see that the initial algorithm starts off the same with what we call the circle of life. Good CPR, applying to the monitor, make sure you're ventilating them appropriately, managing basic airway appropriately, get the heart monitor and pads on, and in this case, when the patient does not have a shockable rhythm, the next sequence is to administer epinephrine as early on as possible. What the most current studies are showing is that if you give epinephrine early on in asystole or PEA, it's more likely to give you ROSC, or return of circulation, versus waiting till longer in the sequence. That said, an interesting point is that there's not a lot of great support to say that giving anybody epinephrine during cardiac arrest is going to increase their hospital discharge survival. Kind of interesting. So in the asystole or pulseless electrical activity algorithm, all we're doing is every other stop, or every 4 minutes, if you will, giving more epinephrine. Now, in these algorithms, we're also looking early on at the H's and the T's. So if you knew the patient was hypovolemic because of trauma, along with your early epinephrine, you certainly could give them some fluid challenges and be looking at getting them somewhere to reverse their hypovolemia. If you knew they were hyperkalemic, you might add something to reverse that. If you knew they had an overdose, we might do something to reverse that, as appropriate at the team leader's discretion. At the end of each of these, we'll talk about what to do once we get a pulse back, but for now, the algorithms are fairly simple if you really look at that and you follow our 4-minute sequence and realize that there's not a lot of medications that routinely need to be given. So as we look at this post-resuscitation algorithm, it's a little bit busy, but it shows exactly what we said. Once we're doing good CPR and we've returned a pulse to the patient, we optimize his oxygenation and ventilation by maintaining adequate saturations, whether that means putting him on an oxygen mask, whether that means giving him back valve mask, or whether that means letting him breathe on his own, depending on his status. Maintaining an O2 sat, 94 to 99. Maintaining a CO2, 35 to 45. And then stabilizing the 3 things in order. Heart rate, we want a normal heart rate, so between 50 and 100. We don't start changing it unless it's significantly below 50 and maintaining, or unless it's over 150 and maintaining. Sometimes post-arrest patients will just be a little bit tachycardic or bradycardic and frequently fix that on their own. Fix the rhythm if that's appropriate. Well, so what that might mean is somebody might need to order an infusion of whatever antiarrhythmic was given to that patient during the arrest. And then fix the blood pressure, as we spoke about in pharmacology. Fluids, as long as the patient is allowed to have fluids, meaning he doesn't have congestive heart failure, if the blood pressure systolic is below 90. If that doesn't work, then inotropes, such as an infusion of norepinephrine or epinephrine, or possibly even dopamine, though not used as frequently. And then stratify the patient as to where they're going to go. 12-lead ECG to determine if they go to cath lab or if they go to the ICU, and then determine if they're a candidate for your hypothermia protocol or your hypothermia team, whoever does that where you happen to work. Do they have a response appropriate to pain or verbal stimuli? So when we're managing patients with bradycardia, whether it's pre-cardiac arrest or post-cardiac arrest, we talked about medications earlier. Now let's talk about some other potential sequences that we could use. So if the heart rate is below 50 and the patient is symptomatic with low blood pressure, decreased level of consciousness, or ventricular ectopic beat, and he's not getting better, you may get ordered to try a dose of atropine or several doses of atropine at 0.5 milligrams per dose. If the patient has a heart block, we may use the atropine or we may use a pacemaker to manage that patient. But also that patient who has a bradycardia that doesn't respond may get dopamine as an infusion or epinephrine as an infusion. So what American Heart and the ECC Council and the American Red Cross tell us is that it is acceptable for bradycardia to use atropine when appropriate, or a pacemaker, external pacemaker, or an infusion of either dopamine or epinephrine in order to bring the patient's blood pressure back up. So this algorithm reviews each of the steps for bradycardia and the potential options at the physician's discretion. So when we look at the tachycardia dysrhythmias, which is heart rates over 150, we break those down two ways. One is with a narrow QRS complex, and the other is with a wide QRS complex. The wide QRS complex, at least for ACLS, we'll talk about as being ventricular tachycardia. Certainly advanced practitioners may recognize wide complex tachycardias that are not ventricular tachycardia, but we're going to talk about just the wide complex ventricular tachycardia versus the narrow complex supraventricular tachycardia. So let's look at the left side of the screen first, which is the narrow complex patient who is stable, meaning the patient has maintained his blood pressure, his mentation, is not having any serious chest pain or pulmonary congestion. The general management looks like this. Assess the patient to make sure he's stable, get him on all the monitors, review his history and exam, make sure he has an IV. If we have time to do a 12-lead ECG when the patient is stable, ideally it's nice to have a 12-lead ECG for the cardiology folks. And the treatment for narrow complex, regular QRS to QRS or R to R rhythms that are over 150 would be a dose of adenosine at 6 milligrams. If adenosine does not work in 6 milligrams, we can try adenosine in 12 milligrams. If the patient has atrial fibrillation or atrial flutter, adenosine is not used just because it doesn't work in those rhythms. So in that case, you might have to use a calcium channel blocker or a beta blocker. So the physician could order diltiazem, atenolol, metoprolol, something like that. So let's look at that patient who becomes unstable now. And here's what we say. If you have one of four things, we're going to call you unstable. If you have C, chest pain, serious chest pain, along with your heart rate sustained at over 150. If you have A, altered mentation. If you have S, shortness of breath with pulmonary edema. Or if you have H, hypotension. If you have cash, you're going to buy yourself some jewels. So we're going to give you synchronized cardioversion if your heart rate is over 150 and you have either serious chest pain, altered mentation, shortness of breath with pulmonary edema, or hypotension. And we're going to start synchronized cardioversion at 100 joules. If the patient has atrial fibrillation, the physician may choose to start at a higher energy level than the 100 joules. But the general is we start them at 50 to 100 joules, and just for ease of teaching, we'll say 100 joules. Synchronized, which means you have to turn the synchronizer on the defibrillator. If we're talking about wide complex tachycardia, the initial management is going to be the same. So get them on the monitor, make sure you have vascular access, try to get a 12-lead if you can, and then we're going to administer either amiodarone, procainamide, lidocaine, or sotalol at the physician's discretion. Most commonly right now we're seeing that amiodarone is our standard go-to medication. However, certainly there's nothing wrong with any of those others at the physician's discretion. If this patient in VTAC becomes unstable at any point in time, that is, has any of those four signs of CASH, any one of them, he too or she too should be synchronized cardioverted starting at 100 joules. And then we increase the energy with each subsequent cardioversion if need be. All right, so as a quick review of what we just said, I know that was a lot of talking. If the patient has a heart rate over 150 and they do have a pulse, here's what we say. If tachycardic and awake, first we try to medicate. If tachycardic with a nap, decreased consciousness, or hypotension, then the treatment is zap, zap, zap. So if we look at the stable patients, of the top rhythm of SVT, we could try vagal maneuvers first for them, certainly better than giving them medication if it works. If not, adenosine or calcium channel blockers or beta blockers at the physician's discretion. Remember that if the patient has AFib or A-flutter, adenosine doesn't work. Some people will try vagal maneuvers, though they generally don't work well in these rhythms, but not going to hurt to try if the patient's able to. And then we either give a calcium channel blocker or a beta blocker. And if the patient is in ventricular tachycardia, the treatment is amiodarone, 150 milligrams over 10 minutes. Remember, we have to give it slowly so they don't get hypotensive. And if the patient becomes unstable with any of those signs of CASH, they're going to be synchronized, cardioverted for their treatment. As we finish up here, we're just going to look at strokes and what we need to remember for the ACLS class. Certainly there's a lot more on strokes with NIH stroke scales and more in-depth stroke scales than what are in the initial provider for ACLS courses, but here's the intro to strokes. So generally remember that we have 3 hours from the onset of symptoms to get fibrinolytic therapy to the patient if he or she is a candidate, so things need to move fairly quickly. Realize that in some facilities that have advanced stroke care, primary or comprehensive stroke care, they may extend that time to longer. And if we're doing interventional procedures, we may even go longer with treatment, 12 hours or longer with interventional procedures where we're actually taking the clot out. So what we say is recognize quickly, rapid Cincinnati bedside assessment, which is 3 things. Facial droop, facial symmetry. Can the patient smile and is it equal? Speech, have them repeat a sentence back to you. You can't teach an old dog new tricks. Or the sky is blue in Cincinnati. Can they repeat it back? Can they phonate it and can they cognate it? Meaning can they make the words and are they saying the correct words? And then arm drift, where we place the arms palm up, have the patient close their eyes for roughly 10 seconds and see if both their arms stay up. Remember that other quick bedside test that we will do, glucose to make sure our problem is not glucose, and then our goal is to get this patient to the neuro section to get a CT scan and determine if they're a candidate. So the general rule is 25 minutes to get them CT'd, 45 minutes to have it read by the expert who reads them at your facility, and then off to whatever specialist would either give them a fibrinolytic or do an invasive procedure at your facility or the facility that you're taking the patient to. So at this point, as long as you've mastered all this information, you should be ready to put this together into case management and overseeing patients having cardiac events, both perfusing and arrested.